Module 5, Cardiovascular System. We are going over Chapter 28, which is the assessment of the cardiovascular system. So we're going to start with the overview. So the primary function of our heart is to deliver oxygenated blood to tissues and return deoxygenated blood to the heart. Sounds so simple, but we need this to live. These are the major anatomical structures of the heart, which we'll talk about more in depth in a minute. So what is our vascular system? When you hear the word vascular, you should be thinking vessels. So we have arteries and veins in our body, and between those two and capillaries, that is how circulation happens. So the main functions of our vascular system is going to be the delivery of oxygenated blood to the tissues, the removal of waste and transportation of cellular waste for excretion, the return of circulatory volume to the right side of the heart, and the return of lymph fluid back into general circulation. So let's talk a little bit more in depth about our arteries. So this is a high pressure system, and because of all that pressure, the walls of the vessels are pretty thick and muscular. And with the exception of our pulmonary artery, our arteries carry oxygenated blood from the heart to the rest of the tissues. And the way it starts is it travels from the arteries to the arterioles to the meta-arterioles down to the capillaries. And let's take a look at our veins. So this is a low pressure system, and veins have valves, and this is to prevent the backflow of blood because veins have to return blood all the way up back to the heart, and gravity is against us, so we don't need backflow of the blood, we don't need it pooling. So this is going to carry blood from the capillary bed through the venules, through veins, and then back to the right side of the heart. So what's nice about veins and what's necessary about veins is that they have the ability to adapt to changes in volume without large changes in pressure. So they're able to dilate and constrict, enough to kind of maintain homeostasis. Then we have our capillary system. So this is where all the magic happens. This is where oxygen and nutrients are delivered and cellular waste is removed. And we have billions of capillaries in our body. Also, our capillaries have these little sphincters that can close each capillary by constricting it, or they can actually dilate and open it to deliver or divert blood to areas of need. And this is just based on what's going on in our body. If you are in the snow and your body senses, hey, it's getting pretty cold, we need to kind of like divert blood to the heart to keep us warm, then it's going to shunt and close off those little sphincters in our hands and our feet to kind of like preserve ourselves. So that's pretty interesting. Here's a comparison of an artery and a vein. You can see that the artery is thick, okay, lots of muscles in the artery, and then we have our vein. It's pretty big, it's kind of flexible. We have our capillary that's very, very tiny. The wall of the capillary is made of a single layer of cells, and then, like I've said, only one single file line of red blood cells can fit in that capillary, so it is very, very tiny. This image shows arterial and venous blood flow through the systemic circulation. So you can see here where the main capillary beds are located in the body. So let's take a closer look at the heart. So our heart is located in our chest. It sits behind the sternum, a really thick bone where it's protected. It's hollow. It is about the size of your fist, and it lies just above the diaphragm. These are the layers of the heart. So we have our endocardium, which is the most inner layer of our heart. It also lines our valves. The myocardium, which is the muscle section of our heart. The epicardium, which is the layer outside of that muscle. And then we have the pericardium, which is like the sac that the heart sits in. So here are chambers and valves of the heart. So we have 4 chambers. We have the 2 atrium and the 2 ventricles. And then we have valves. So we have our AV valves, or atrioventricular valves, which connect the atrium to the ventricles. So we have our tricuspid, which is the yellow circle here. And then our bicuspid, or we also can call that as the mitral valve, over here between the left atrium and the left ventricle. Then we have our semilunar valves, the pulmonic and the aortic valves. So the pulmonic valves collect the blood from the right ventricle and then ships it off to the lungs to get oxygenated. When it comes back to the left atrium via the pulmonary veins down to the left ventricle. When the left ventricle squeezes, it's going to squeeze into the aortic valve, which will then take it to the rest of the body. And you can see in this image here that blood moving through the heart through those valves. So more in depth here is the pathway of blood through the heart. So we have 1 through 6 straight from your textbook. You should be able to say this out loud without looking at your notes. So let's talk it out. So we can follow in this picture that blood is going to enter the right atria of the heart from the superior vena cava and the inferior vena cava. Those are veins, right? That's deoxygenated blood. It's coming into the right atria. It's going to go into the right ventricle through the tricuspid valve. From there, the right ventricle is going to contract and push that blood through the pulmonary artery via the pulmonic valve. And that's going to take it to the lungs for gas exchange, hopefully. It's going to pick up that oxygen, and then it's going to come back to the heart via the left atria from the pulmonary veins. It's going to go to the left ventricle through the mitral valve. The ventricles are going to squeeze, and that left ventricle is going to squeeze the heart through the aortic valve, through to the aorta, down to the rest of the body so it can systemically provide circulation.
Blood returns from the body to the heart via the superior and inferior vena cavae. It first enters into the right atrium, then through the tricuspid valve and into the right ventricle. The right ventricle pumps the deoxygenated blood through the pulmonary artery to the lungs. The oxygenated blood returns back to the heart through the pulmonary vein and into the left atrium. It goes through the mitral valve and finally into the left ventricle, which is responsible for pumping the oxygenated blood through the aorta and out to the body.
Okay, so now that we know the blood flow through the heart, now let's take a look at the blood flow that's actually supplying blood to the heart muscle itself. So this is the left coronary artery. There's a little star here for left, and this includes two branches, the left anterior descending branch, or LAD, and the circumflex branch, which are all labeled here. And these arteries are going to supply blood to both ventricles, to that septum, to the anterior wall of the heart, the left atrium, and the posterior wall of the left ventricle. So if you have a clot or some kind of obstruction in the LAD or the circumflex branch way high up, then you could potentially cut off blood to all of these things. It's pretty much the whole left side of the heart. And then with the right coronary artery, you see the star here for the right side. Again, if you had a block high up, then it's going to affect all of these vessels down below it. And this is just another image of the blood supply to the heart. Now we're moving on to the cardiac conduction system. So this is a picture of the cardiac conduction system, and the green lines represent the pathways that the electrical impulse follows through every cardiac conduction cycle. So here we see the sinoatrial node, the SA node, and it is where it all starts. This is where it should start in a normal sinus rhythm. From the SA node, it's going to branch out to Bachmann's bundle here to the other atrium, and it's going to go down this middle tract here, and it's going to ultimately go to the AV node. So the sinoatrial node will trigger, and at the same exact time, it's going to send a message to the other atrium to contract. So they're going to contract at the same time. They're going to come here to the AV node, the atrioventricular node, which is the gatekeeper. And it's going to say, stop a minute, okay? And it kind of causes this pause. Again, we're talking about fractions of a second. This is going to allow time for the ventricles to fill with blood. Once that time has passed, then the AV node will let the signal pass, and it's going to go down through the bundle of His right here, through the interventricular septum of the heart, this little piece of meat, into the left bundle branch and the right bundle branch. From there, it's going to wrap around the ventricles, and the Purkinje fibers are these little fibers here at the end, and the ventricles will contract. So this is another depiction of the cardiac conduction cycle. This is numbered. This is copy-paste from your textbook, so you need to remember this, the order. Number 1, SA node, 2, AV node, bundle of His, right and left bundle branches, and then the Purkinje fibers.
This animation explains how a cardiac cycle is produced by electrical impulses in the heart. The cardiac cycle starts when an electrical impulse or action potential is generated by the sinoatrial node. The electrical impulse travels along specialized conducting fibers in the walls of the atria, stimulating the atria to contract and pump blood into the ventricles. In the normal heart, impulse travels very rapidly. As a result, all the muscle cells in the atria contract together, producing a coordinated pumping action. The impulse also travels across the right atrium to the atrioventricular node, where it is delayed slightly to allow the ventricles to relax and fill with blood before they contract. The impulse travels along the bundle of His, where the conducting pathways divide in two, forming the left and right bundle branches, which lie in the interventricular septum. From the bundle branches, the impulse spreads into the inner walls of the ventricles via specialized conducting fibers, called Purkinje fibers. Finally, the impulse travels up the outer walls of the ventricles towards the atria. The rapid and controlled spread of the electrical impulse through the ventricles stimulates the muscle cells in the ventricles to contract together and pump blood efficiently to the lungs and body. As you will see, during atrial fibrillation, the electrical activity of the atria becomes disorganized. As a result, the pumping function of the atria is lost, and the rhythm and efficiency of the entire heart are disturbed.
Okay, so here we have a picture of the SA node, AV node, and Purkinje fibers. So they each are like mini pacemakers. Now our main pacemaker is the SA node, which beats at 60 to 100 beats per minute. That's how many times it fires. The AV node will fire at about 40 to 60 beats per minute, and the Purkinje will be 30 to 40 a minute. So if your SA node fails, then the backup will be that AV node, and if that fails, Purkinje fibers may be able to keep the ventricles contracting. The cardiac cycle, so what is it? So the cardiac cycle is the sequence of events where the heart fills with blood and then there's ejection of blood. That's pretty much what the cardiac cycle is. It's the lub-dub that we hear. It is our heartbeat. That is the cardiac cycle. And then quick mention, blood pressure is a reflection of these pressures generated during that cardiac cycle. So let's talk about blood pressure. So by definition, blood pressure is the force exerted against the vessel wall by blood flow. So as your heart pumps out blood through that aorta systemically, with every beat, it's a little bit more pressure against the wall, so that's going to be part of our blood pressure. And then in between beats, where we don't have that full pressure of the heart contracting, when it's just kind of waiting, that is our other blood pressure, systolic and diastolic, which we'll talk about more in depth in a second. So factors that influence blood pressure are going to be the amount of blood ejected during systole, which is considered our cardiac output, and the resistance to flow in the peripheral vessels, which is going to be our peripheral vascular resistance, or PVR for short. Moving on to cardiac output. So cardiac output is the amount of blood the heart pumps out in 1 minute. Normal cardiac output in an adult is roughly about 4 to 8 liters per minute, which if you think about it is quite a bit. The formula for cardiac output is heart rate times stroke volume. And we're pretty familiar with heart rate. It's the number of cardiac contractions per minute, and we know it can be influenced by many things. Stroke volume. So stroke volume is the amount of blood ejected with each ventricular contraction. So what's the difference between cardiac output and stroke volume? So cardiac output has to do with time, so all the blood that comes out in 1 minute. Stroke volume is just the amount of blood that the ventricles squeeze out during one squeeze. And this can be influenced by preload, contractility, and afterload. So why is cardiac output so important? Well, so we know that the normal cardiac output in an adult is 4 to 8 liters per minute. So if you have a patient who has, say, 2 liters per minute of cardiac output, that means that there's not enough oxygen-rich blood coming out of the heart to support homeostasis. That means that the body is going to be oxygen deprived and that the cells, tissues, and organs are not going to be perfused adequately. So let's talk about the things that influence stroke volume, starting with preload. So preload is the load on the ventricular muscle at the end of diastole. So remember, diastole is when the ventricles are at rest and they're filling, so they're not contracting. So the load at the very last moment before they squeeze is called the preload. Factors that influence preload is going to be circulating blood volume. So if you have a lot of blood in circulation, then you're probably going to have a higher preload, because preload is the amount that's in the ventricle before it squeezes. Venous tone. So remember what fills the right side of the heart. Where is the blood coming from? It is our superior and inferior vena cava, which is a vein. So are they dilated? Are they constricted? That's going to affect the amount of blood coming into the heart. Next is muscle contraction. For example, during exercise. So you're exercising, your body knows, hey, we need more oxygen, we need more blood flow. So it starts to contract more, and that is going to lead to increased preload. Cardiac valve function. So we have this valve in between our atrium and our ventricles, and if it's not working right, then those ventricles aren't going to be filling appropriately, which is going to probably result in a decreased preload. And then heart failure. So we haven't talked about heart failure yet. You'll be talking more about that in your next Med-Surg class, but pretty much the idea with heart failure is that the actual heart muscle, it can be either the left side, the right side, or both, but the actual muscle has become weak. So if the heart muscle is too weak to effectively pump out, the blood from the ventricle, then you're going to have less preload, right? Because the blood isn't coming in. Maybe it's going to pool, maybe it's not going to get filled adequately. So that's going to lead to less preload. So if you look at this little blue box here, this is something that you may want to remember. When you have increased preload, so you have bigger volume in those ventricles, you're going to have increased cardiac output. You're going to have more coming out. If you have decreased preloads, so you don't have as much volume in there, then you're going to have decreased cardiac output. And I think this concept makes pretty good sense. Next, let's talk about contractility. So this is the force of mechanical contraction. So you see this picture here, it has muscles, it's strong. It's the force of that actual squeezing of the heart muscle. So things that can influence contractility, again, our central nervous system, hormones, ions, aka electrolytes, medications, pathological conditions like diseases of the heart, age, genetics. So a lot of things. And then this blue box here says if you have increased contractility, so your heart is squeezing really strong, then you're going to have increased cardiac output. And that makes sense because your heart's able to squeeze out all of that volume that's in the ventricles. And then the reverse is also true. If you have decreased contractility, then you'll have decreased cardiac output. And finally, our third component is afterload. So afterload is the pressure against which the heart will work. So how hard does that heart have to work in order to get the blood out of it, for that blood to go into our circulation, into the vascular system? So this is determined by peripheral artery resistance. So how hard is that resistance? If you go through something that has a lot of resistance, it's not going to go in very smoothly, not very easily. So the greater the resistance that blood has to get through the vessels, then the increased afterload. So things that influence contractility are blood pressure, the vessel lumen diameter. So is the vessel dilated? Is the vessel constricted? Do you have a lot of plaque buildup? Are the walls really stiff and they're small now, or constricted, narrowed? So that's going to affect how hard the heart has to work to get the blood through that vessel. And then vessel compliance. So how well is that vessel kind of able to flex and accommodate the blood coming in, or is it very stiff? If it's very stiff, that means it does not have a lot of compliance. So the heart has to work even harder to get the blood through. So this blue box, if you have increased afterload, then you're going to have decreased cardiac output. If it's really hard for the heart to get the blood out, then there's not going to be a lot of blood coming out. Decreased afterload equals increased cardiac output. So if the heart doesn't have to work that hard to get the blood out, then it's going to get the blood out and you're going to have increased cardiac output. So there is a formula that you can use to determine a patient's cardiac output, but in practice, these patients are typically really sick, they're critically ill, so they're most likely going to be in the ICU if we need to know exactly what their cardiac output is. And this is going to be measured through a central line. So a central line is placed all the way through the heart, and there is a probe there that can measure like the preload, afterload, and cardiac output.
With each contraction of the ventricles, blood is pumped out of the heart. Stroke volume is the amount of blood a ventricle pumps out in one contraction. Cardiac output is the volume of blood that each ventricle ejects every minute. To find the cardiac output volume, multiply the number of heartbeats in 1 minute by the stroke volume. At rest, the cardiac output for an average adult male is about 5.25 liters, 4.9 liters for an adult woman. Cardiac output increases with physical activity, rising to a maximum that may be 4 to 7 times greater than the resting output. This difference between resting and maximum output is known as cardiac reserve. Heart rate and stroke volume are regulated by the autonomic nervous system and by hormones in the bloodstream. Other factors such as age, weight, and physical fitness also influence cardiac output.
This is just a couple of pictures to visualize preload and afterload. Next is blood pressure. So blood pressure is cardiac output times peripheral vascular resistance, or PVR. So PVR is the resistance that the blood encounters as it flows through the blood vessels to the periphery of the body. So PVR influences the force required to circulate through the arteries. Things that influence PVR. So vessel diameter. If the vessels are constricted or they're very dilated, or if there's like plaques like arteriosclerosis, that is going to affect how well that blood goes through that vessel. So if it's a very wide vessel versus a very constricted vessel, it might be more or less blood. Blood viscosity. So if you have really thick blood, if the patient has a high hematocrit, maybe they have lost some blood volume, maybe they are dehydrated and their blood is really thick, then that can also affect how well the blood moves through the vessel, peripheral vascular resistance. Body weight and height. So there's more surface area that the blood has to travel through. Think about an 8-foot tall person. The blood from their toes has to go all the way back up to their torso, right, to their heart. So that is increased peripheral vascular resistance. Compliance and elasticity of vessels. So compliance is the ability of the vessel to stretch, okay, to dilate, to get bigger. And elasticity is the tendency of that stretched vessel to return back to its normal size. So compliance is inversely related to elasticity. One is dilating and one is going back to the normal size. So it's this action that can also affect blood pressure. Blood pressure. So when we take a blood pressure, we get two numbers, two pressures, systolic and diastolic. So what do those two terms actually mean? So systolic pressure is when the ventricles squeeze. They squeeze out the blood, and during that squeeze, it's pretty high pressure in our artery. When the left side of the heart squeezes out the blood that goes into the aorta, which then goes into the rest of our body, it's a pretty big kick. So the blood squeezes out and it hits our vessel walls all throughout our whole body at the same time because the arteries are that strong. It is that force against the wall that is our systolic blood pressure. Then, during our cardiac cycle, after the blood is pushed out of the ventricles are now filling, they're at rest. So during that time where they're at rest, those arteries that just kind of had all that blood squeezed against them and they kind of expanded a little bit, well, now they went back to their normal size because the ventricles are filling, so there's not that extra pressure of blood shooting at them. That is our diastolic pressure. When the ventricles are filling, it's the pressure that's on the vessels at that time. So if you see here, we have 120 over 70. So in reality, this is a range. It's a range of artery pressure. So if you have a blood pressure 120 over 70, that means at any given time, the range of blood pressure in your vessels varies from 70 to 120. This slide just has some facts about blood pressure, and I'll just read them to you before we move on. So blood pressure. The primary factor that determines systolic blood pressure is stroke volume. The increase in preload or increase in contractility will increase stroke volume, which will increase your systolic blood pressure. A decrease in compliance of vessels also increases systolic blood pressure. And the primary factor for determining systolic blood pressure is total peripheral resistance. Do you need to memorize this? Not really, but if you can go through each one, you can see there are many factors that influence blood pressure. Mean arterial pressure, or MAP. So what is it? So the MAP is the average blood pressure maintained through the cardiac cycle. So during systole, which is when the ventricles are contracting, it only takes about 1/3 of the cycle. Okay, so let's think about this like, say we're talking about minutes. It's not minutes, it's fractions of a second, but minutes are easier to talk about. So say it takes 1 minute for a cardiac cycle. 1 minute meaning, they fill up with blood and then they squeeze out. So we'll pretend that the squeezing of the heart takes 33 seconds, but the filling time takes 66 seconds. It's 2/3 of that time. Okay, so this is important when you are trying to determine what the MAP is. So we're talking about the time it takes. So one is 1/3, the other takes 2/3 of the cycle. So if you had a blood pressure of 120 over 70, we have a little formula. Because it takes 2/3 of the time during diastole, whatever the bottom number is, we're going to count that as twice. So we're going to do 70 plus 70. Okay, so 2 times diastolic blood pressure plus systolic blood pressure. So it's going to be 70 plus 70 plus 120. Then we're going to divide it by 3 to get the average. So the MAP for this blood pressure would be 86.6. So how is this significant to us? So we know, studies have shown, scientists, doctors have determined that the body needs a minimum MAP of 60 millimeters of mercury in order to maintain perfusion to our vital organs. So if you take a blood pressure and your MAP is above 60, even though the blood pressure itself might be low, but your MAP is above 60, then we'll say that the organs are still being perfused. But if you have a blood pressure where that MAP is below 60, then we know we need to do something more urgently. Now you may hear in ICU, they look at the MAP a lot. That's because the patients are very unstable and they're typically on these really potent medications for blood pressure, IV. So monitoring that MAP and that organ perfusion is really important. And this varies slightly, with changes. It varies, not slightly, more accurately and more in real time. When you are taking a blood pressure on a Med-Surg unit, we don't typically look at the MAP too often because those patients are more stable. Next, we're moving on to assessment. So our assessment will start with an interview, and we want to ask about the patient's history. So we want to know about their family history of cardiovascular disease, diabetes, chronic kidney disease, hypertension, and dyslipidemia, or high cholesterol. So these things tend to run in families. So if they have a close family member that has this, then it puts them at high risk for having it too. We have our non-modifiable risk factors that include age, sex, and ethnic background. And we have our modifiable risk factors: weight, dietary habits, alcohol consumption, smoking history, and activity level. So these are all things that they can change. So if they have any of these risk factors, then we're going to want to educate them to not have them, right? Socioeconomic status as well. Studies have shown that if they live in a lower socioeconomic status, then they're likely to have more chronic diseases. Current health problems. Do they have diabetes, CKD, hypertension, high cholesterol? Those are all risk factors, like I mentioned above, for cardiovascular disease. Do they have chest pain? Do they get short of breath? Do they have cough? Are they fatigued? Do they ever have episodes of syncope or near syncope where they feel like they're going to faint? If the patient says, yes, I have chest pain, then we are going to want to ask more details, more information. Where is it? How severe is it? Does it radiate? How long does it last? And what exactly does it feel like? Is it chest pain? Is it sharp? Is it burning? Is it stabbing? Does it feel like pressure? Shortness of breath and fatigue. Do you have this when you're doing physical activity, like when you're exercising? Does it stop when you rest? Or do you have dyspnea and fatigue at rest, which would be worse than not? Do you have palpitations? Do you feel like your heart is racing? This could be indicative of a dysrhythmia. Syncope. Do you feel like you're going to pass out, or did you actually pass out? This could be decreased cardiac output, because remember, when you think of cardiac output, you're thinking oxygen perfusion. So if there's not a lot of oxygen perfusing, especially to your brain, then that will cause you to pass out. Weight gain. So if they've had some recent unintentional weight gain, I don't know who intends to gain weight, but we want to check for edema because that could indicate heart failure. And then we have our physical assessment. So we're going to do our complete head to toe assessment. We're going to be looking at the color, the skin moisture, are they diaphoretic, presence of edema, restlessness, agitation, and confusion that can be related to hypoxia. Weight, have they gained weight recently? Are they short of breath? What's their mobility status? And we want to take their vital signs and especially assess that blood pressure and heart rate. So a patient that has cardiac issues, they might be pale, they might be fatigued or short of breath. Patients that have heart failure, severe heart failure, might have edema and fatigue. So it's important to do a thorough, focused cardiac assessment. A little more information about why the heart rate and blood pressure are so important in cardiovascular disease. So the heart rate tells us how efficient and how strong the heart is. So if you have a decreased heart rate, it might just be that you have good physical conditioning, right? If you're bradycardic and you're an athlete, then that's your baseline, your normal baseline. But a decreased heart rate otherwise could mean inadequate cardiac output. A decreased heart rate with dizziness, shortness of breath, or chest pain, which means symptomatic, you have to investigate further. An increased heart rate is normal if you are exercising, right? If you're running around the block and your heart rate goes up to 150, 160, we expect that is normal. But if you have an increased heart rate when you're at rest, that is abnormal. Some things that can cause this are pain, fever. Okay, we expect that. If your heart is weak, it's going to try to compensate and increase the rate. And we know that hypovolemia can cause increased heart rate because your heart is compensating for that decreased volume of blood. Pulse deficit. That is when you check the radial pulse and the rate is lower than the apical pulse. So that can indicate an arrhythmia. So then blood pressure. So the blood pressure is going to tell us the force of the heart's contraction and volume of cardiac output, an estimation. So if you have decreased blood pressure that is symptomatic and it causes postural hypotension or aka orthostatic hypotension, or if you get dizzy or shortness of breath or you pass out, this could mean an inadequate cardiac output or low blood volume, so you need to do something about it. If you have an increased blood pressure, that could indicate more resistance in the blood vessels, which means our body needs to up that blood pressure to produce enough cardiac output. Increased blood pressure will also put you at risk at heart failure, myocardial infarction, and stroke, which is why it's so important to maintain a healthy, regular blood pressure. Continuing on with our physical assessment. So color, cyanosis. And one thing to note is that when you assess the cardiovascular system, we usually assess the respiratory system at the same time because they're buddies, they're friends, they go hand in hand. So cyanosis, the blue skin can indicate an issue with the heart or the lung. Capillary refill time, circulation. Distension of jugular veins could indicate hypervolemia. Clubbing of fingers or toes, this is something chronic long-term perfusion problems. Inspection, edema. So you look at the picture, this is all edema. The top 3 pictures here are pitting edema. Okay, you put your finger down and it leaves a pit and it takes a few seconds for it to normalize. If they have bilateral lower extremity and if it's not an injury they had, then that could be venous insufficiency or it could even be heart failure. And I'm not mentioning kidney problems because we're talking about the cardiovascular system right now. If you have one extremity that's edematous and they did not have an injury there, then we may consider it some type of obstruction, maybe like a DVT, or even something in the lymphatic vessels that are obstructed. So pitting or non-pitting, again, pitting is when you push down and it leaves a dip. Non-pitting is not going to leave that dip. So some causes of non-pitting edema, there's very few, would be lymphedema, like this picture here, myxedema, and lymphedema. So we go to palpation. So this includes checking the skin temperature. We don't want really cold extremities because our body is warm. So cold would mean maybe vasoconstriction for some reason, heart failure, or even shock. If you have temperatures that are warm on one side and cold on the other, that's a red flag. So we always check both sides of the body to make sure that they're equal. Pulses, so palpable pulses, strong, indicate adequate cardiac output and good flow through the peripheral vessels. Also, part of our focused cardiac assessment would be auscultating those heart sounds. So we want to hear the S1 and S2 sounds. So the S1 sound refers to those tricuspid and mitral valve closing, those AV valves closing. And then the S2 are those pulmonic and aortic valves closing. So lub-dub, that is what we want to hear. And then this table 28.2 is a summary of heart sounds. So you can kind of read through them to see what those other sounds indicate. And during our cardiac assessment, we also want to listen to lung sounds. When you have nice, clear lung sounds, that means you have healthy heart and lungs. If you hear rales, crackles, rhonchi, and other adventitious sounds, that can be indicative of some type of pulmonary lung disease, even congestive heart failure, the buildup of fluid, or even just decreased cardiac function. So they all work together. So we definitely want to assess those lung sounds. So next we're going to talk about our labs. So laboratory markers as predictors of heart disease. Our lipid panel. So we should get our labs drawn every year as part of our annual exam. So for the lipid panel, the patient should fast about 8 to 12 hours before the test so we can get the most accurate results. This is going to include total cholesterol, LDL, HDL, and triglycerides. So cholesterol, we need cholesterol, a certain amount of cholesterol, because this lipid is necessary for our cell walls. It's in our cell wall, so we do need some cholesterol. And triglycerides, which is a type of lipid, store unused ingested calories in fat cells, which will be later used as an energy source. And our goal for triglycerides is less than 150. So let's get to know LDL and HDL. So let's start with cholesterol. So where does cholesterol come from? We have to consume it in animal products. So this can include meat, poultry, dairy, eggs. But we can also get it without ingesting anything because the liver can synthesize it all by itself without us consuming it. Cholesterol is a fat-like waxy substance that just floats around in our blood. It is not soluble in blood, okay, so it just floats around. So our liver makes proteins that combine with cholesterol to form two types of lipoproteins, LDL and HDL. LDL and HDL are transporters. So let's look at this first truck here. This is LDL and it's carrying cholesterol, and its job is to transport cholesterol either into the cell or into arterial vessel walls. That's not a good thing. We don't want it going in our cell, and we definitely don't want it in our vessel walls. HDL transports it to get it out of the body, transports it to the liver for excretion. So we want our LDL low and we want our HDL high because we want more transporters that are going to take it out, on the road to excretion. We don't want a lot of LDL because those cells are going to store it in our, transport it into the cell and transport it into vessel walls. So our levels here, the goal for LDL is less than 100 and the goal for HDL is actually more than 40 or 60. Of course, the higher the number, the better. So how does the liver excrete it? Well, the liver is going to turn it into bile. And remember, bile is stored in the gallbladder and is released in the small intestine to help break down fats and stuff. So this is LDL and HDL. So more diagnostic studies, markers of acute cardiac damage or injury. So we have creatinine kinase or CK. So this is a general marker of cellular injury. It doesn't tell us where or where the injury is or what is being injured. It's just a general marker. So yes, we can look at this. If it's elevated, then it's just another clue to what the problem is. Creatinine kinase myocardial bands, CKMB, is specific to cardiac tissue. So if you have high levels of CKMB, it can be seen as early as 3 hours after that damage has happened, and it can remain elevated for up to 36 hours before it goes back to normal. Then we have troponin. So troponin is something you probably have heard more commonly, and it is the gold standard. This is released from damaged tissue, and this starts to elevate within 4 hours of the injury, and it can actually stay elevated for up to 10 days, much, much longer. And that makes it a valuable marker when trying to see what happened in the recent past. So we can see, oh, you have an elevated troponin. So within 10 days, they could have had something that happened at least 10 days ago. So it's just another clue. Myoglobin is a protein inside muscle cells. So if you have a high level, it means that you've had muscle damage. But again, it doesn't tell you what muscle or where in the body. Brain natric peptide or BNP. This is released from overstretched ventricular tissue, and this is an indicator of heart failure. So then here I wrote serial draws because these types of blood tests are done every few hours to see trends. So troponin, for example, if you have a patient who came in with chest pain and they drew a troponin, they may do a troponin, every 3 hours for 12 hours or every 6 hours times 2 or 3. So serial draw so they can see the trends. This table is from your textbook. It shows other labs that I didn't mention here and their normal values. The next diagnostic study is the ECG or electrocardiography. Some also say EKG. We're talking about the same thing. So this ECG assesses the electrical conduction system, and whenever a patient has chest pain or any kind of cardiac abnormal assessment, or maybe they're going to have surgery, a 12-lead EKG is what is going to be ordered. So this differs from the 5-lead telemetry monitoring that you may see on a patient that's in the hospital. The 12-lead EKG is much more detailed. So this is going to be able to assess the heart's electrical activity. It can show dysrhythmias, it can show new or old heart muscle damage, electrolyte abnormalities, and some other cardiac issues. So EKGs are very helpful. There are 2 types of electrodes or leads that are used for the EKG, and those are chest leads and limb leads. So you can see on this picture where leads are placed, and then on the next picture you'll see it a little more detailed. So you can see in the picture where these leads are placed, and you'll see that it's really important that you place them correctly so that you can get an accurate depiction of the electrical conduction of the heart. This picture shows you how limb leads and chest leads create an image that we then see on our EKG paper. So on the left you see limb leads here, and on the right you see chest leads. So they communicate with each other, and in the center picture, each lead is kind of like a camera, and it will cross over to the corresponding lead to create that graph picture. That's why placement is important. This is our wave here. This is normal sinus rhythm. Okay, so moving on. So other diagnostic studies, the chest x-ray, very common. It is inexpensive and fast. So if you come in with chest pain, you will have a chest x-ray done. Echocardiogram. This is essentially an ultrasound of the heart. You can either do it on the skin, like topical, or you can actually go in through the esophagus to get a closer view, and it's the same thing, it's an ultrasound. With an echocardiogram, part of your results from the report is going to include ejection fraction or EF. So this is going to be the percentage of blood that is ejected with each ventricle during a contraction. The normal value is going to be 55 to 70% of the total volume. So what that means is with every ventricular contraction, we eject about 55 to 70 of the blood. We don't ever eject 100% of what's in the ventricle. There's always some blood in there left over. So if you have a low ejection fraction, that means that you have a very weak heart. Your heart is just not squeezing enough to reach that at least 55 to 70% of that volume to get it out. So this would be like an indicator of heart failure if you have a really, really weak heart muscle. So if you have a patient with an ejection fraction of 15%, 15, then you really want to be keeping an eye on them because their heart could essentially stop because it's so weak. Cardiac stress tests. So we can have a regular stress test or a nuclear stress test. So the regular stress test involves a patient getting on a treadmill, they're hooked up to an EKG and a blood pressure cuff. And while what we're trying to do is to induce whatever brought them to the hospital. So if the patient came in and said they had chest pain, but they don't have any chest pain anymore, and they did labs and they did an EKG and everything's normal, then they may order a stress test to kind of induce it, to make the heart work so that they can see what happened, when they were at home or whatever. If the patient isn't able to walk on a treadmill, then they will be given a medication to make the heart, act like it's doing, like you're exercising, for the same goal. So this needs to be done in a controlled environment with a crash cart ready because you might cause a myocardial infarction. That's what we're trying to do that, right? So we want to make sure that you have a crash cart and defibrillator available. The next diagnostic study is the coronary catheterization, or also known as cardiac cath. So you see the little umbrella here next to coronary cath. So that means that is an umbrella term. That kind of means any kind of procedure where you're accessing an artery and inserting a small catheter all the way to the heart. We're calling that a coronary catheterization. So there's a lot of reasons why this procedure would be done. But for the most part, they're going in, they can check cardiac filling pressures, cardiac output. They can check to see if the valves are working. And this is all done under fluoroscopy. So fluoroscopy is an x-ray, like a real-time x-ray. So instead of taking one picture, fluoroscopy is like a video. You're seeing it in real time on the screen. So this does require a contrast dye to light up vessels in that image. So just keep that in mind. And this is performed in the cath lab in the hospital. So if you are having symptoms of a MI or if you're having chest pain, you better hope that your hospital has a cath lab. So very important. Coronary angiography or coronary angiogram or cardiac angiogram. Those all mean the same thing. So once you have a cardiac cath, if it's determined that there is a blockage or something needs to be done, then it kind of switches over to be a coronary angiogram. And the purpose of this is to check those arteries for blockage and check to see if revascularization is appropriate. And that's when they may do an intervention. So an intervention means they're actually doing something to fix it versus just, assessing pressures or putting dye to look. An intervention means they're actually doing something. So these patients may have a percutaneous coronary intervention, which is a PCI for short, or coronary artery bypass surgery, or CABG, or we say CABG for short. So when you get your patient from the cath lab after a procedure, the cath lab staff is going to tell you or give you an SBAR report, and you will know what the patient had done. And the post-procedure care for a cath procedure is pretty much the same. It doesn't matter what they got. We're going to treat the patient the same. And then here in this picture on the left-hand side, you see these stars here. So these are the most common sites to access, either the right or left femoral artery, the radial artery, or sometimes, I didn't mark it here, but sometimes they go through the subclavian artery up here, but I've never seen that done, but it is an option. And it is the physician that decides where they're going to go in through. Ideally, the preference is always radial, only because femoral, of where it's located, higher risk for infection. But it really is up to the physician and what they determine which vessels have the best integrity to handle the catheter. Okay, so this picture shows you the steps of the coronary angiography. So in this picture, the catheter is inserted via the femoral artery, and it is guided all the way up to the aorta of the heart, and then it goes into the heart. And as the catheter goes in, it stops at the left coronary artery where there's going to be dye injected there. So then the dye is injected, and all of the heart muscles are then lit up, which is able to show any kind of obstructions or occlusions like in a vessel. This is an example of an intervention, so I'm not sure what they did here, but you can see here in this picture it is occluded. Here it is no longer occluded, and then there's nice free-flowing blood into those vessels. So complications. The patient can die from this. Okay, 1.1 per 10,000 patients will die after a cardiac cath. They can have a heart attack, a myocardial infarction. It can result in pericardial tamponade. They may need bypass surgery emergently, and it can cause stroke. So these are all things that the patient will be warned about before the procedure, and we have to look out for post-procedure. But the most common complications that you're going to see is bleeding, because arteries bleed, hematoma, very similar to bleeding but underneath the skin, and acute kidney injury because of the contrast dye that they use. Pretty potent, and if you have a patient whose kidney function wasn't the greatest prior to this, then it may push them into acute renal failure or even needing, one dialysis treatment or something like that. So post-procedure, your responsibility as the RN. When a patient has had this procedure in the cath lab, they come up to the floor with the cath lab staff, and you will get report then. They will come, if they access the radial artery, they're going to have a device similar to this to put pressure on that artery, but just enough pressure to occlude the artery, but not to obstruct it completely. We don't want to obstruct it because then the hand is going to, not have any blood. So you're going to have this band here. It's going to have a little cuff here filled with fluid, or sorry, filled with air. And then they're going to give you a syringe like this. This is a very special syringe. The tip only fits this. It doesn't fit anything else. It doesn't fit an IV. It doesn't fit a needle. It's a special syringe. So you are going to have to release the air from this little pocket little by little. Like every 30 minutes, you take out 1 ml of air. Next 30 minutes, you take out another ml of air. And then the whole time you're assessing the site, looking for signs and symptoms of bleeding or hematoma. If the patient had their cardiac cath accessed through the groin, then you will have a sandbag. Again, these are really thick, big vessels that they just put a big old catheter through, so the potential for bleeding is very, very high. So you want to make sure that you're assessing the site frequently to make sure the patient doesn't hemorrhage or bleed out. So post-procedure is going to vary slightly between the different facilities that you work at. So you want to maintain the patient flat for at least 2 to 6 hours. Where I worked, it was always 6 hours, and that's to prevent stress on that insertion site. We don't want to cause bleeding. Like I said, you want to make sure you check the site for bleeding or hematoma frequently. You want to keep an eye on the vital signs, because if the patient starts to hemorrhage on the inside, then it's going to reflect that in the blood pressure and heart rate. Remember, the heart rate is the first one to show that tachycardia. We want to make sure we're asking the patient to report chest pain, because it could lead to a myocardial infarction. Stroke, same thing. You're going to look for those signs and symptoms. We want to make sure we're monitoring the pulses, especially on the affected side. So if they went in through the left groin, then we want to make sure we're checking the pulses like in the foot. Make sure urine output is sufficient, because that contrast dye can cause issues, so we want to flush it out. Make sure they're drinking, and IV fluids are in place if as appropriate. And then we want to keep an eye on renal function, hemoglobin, hematocrit, and coag studies. Okay, and that concludes this chapter.